let's get to another poll question here. What is the primary roadblock to developing a PE program at your facility? Not getting the buy-in from administration, not getting the buy-in from other specialties, unsure about the process to implement, unsure about patient stratification and the algorithm for PE, or unsure about the modalities to include in the PE program treatment. So I'll give a minute here for people to respond. All right, responses are coming in here. So it looks like the majority of people are measuring that it's buy-in from all specialties or other specialties and unsure about the process of implementation. And that's what we're going to move on to talk to here, is how to set up your program and how to implement it effectively. So again, the rationale for forming a PE team is you want collaboration, collaborative evaluation, and decision-making. We all have biases in our specialties and biases from individual practitioners, and this helps smooth those out. For PE, there's novel treatments, advancing technologies that emphasize really the need for a multidisciplinary approach. That's flexible, looking at multiple options on a patient-by-patient method. So the team-based decision-making avoids the zero consultation that happens in multiple different opinions kind of collecting over time, and allows for a collaborative opinion to be presented to the patient, the family, and for a decision to be made. So there's a failure to rescue or inability of clinicians to appropriately escalate care out there as well, I think. That can be provided by, but it can be avoided by having a readily available single source number or method of activating that team, similar to a response team as well in the hospital. So goals, again, rapid and accurate risk stratification. Formulate that treatment plan and then mobilize the necessary resources and enact the plan. So assembling a team, I talk about identifying a champion or champions in an institution. Institutions vary dramatically in resources, specialties, in the local politics, committee structures, etc. And a champion is the one who's willing to commit to the heavy lifting of assessing their situation and advancing patient care. So this is the one who figures out what their local situation looks like. What are the committees? Who are the players? And identifying those players. And what resources do we have for treatment? So the champion is the one who really kind of navigates the minefield, so to speak, and collects this information. And the players are the referral team. Where do these PEs land? Who do you have to identify who's going to be referring these people? The clinical decision team, who do you want on that team? What specialties do you want to be a part of this? The treatment team, what specialists do you have in your hospital and what expertise is there? And then the administration. So the referral team, the outpatient, obviously primary care providers in the community, EMS, community education. The ER is the most common and easiest point to capture patients. Is where the majority of patients land. And then the inpatient patients are often on the medicine or hospital service, or the hospitalist is often involved. But it can be on any of the surgical floors, surgical subspecialty, obviously ortho, neurosurgery, spine, and in the critical care unit. So the clinical decision team, this is a quick list of pulmonology, hospitalists, vascular medicine, hematology, radiology, an echo, interventionalist, and then surgeon. It's unusual, I say, for a vascular surgeon, which I apologize for being. I say I commit surgery when I have to, but it's unusual for a vascular surgeon to be a part of or kind of be the champion of this team. But in our institution, that's kind of how it landed. That's how it made sense. And now, of course, we have pulmonology and hospitalists and the others on our team. Radiology is very important as well. They help with reading our chest CTs, on calling that RV strain, and they'll even put that in their comments and in their review when it's clear, and that really helps as well. So assembling the team, the treatment team, the cath lab personnel. This has been a learning experience especially when we're starting for the personnel to know the devices, the catheters, and what we use. The OR, if you do have those abilities with personnel and perfusionists. ICU staff is huge, and troubleshooting, running the catheters, protocols, monitoring parameters is an education effort in the ICU. And as I'll talk, we went from our classic ICU to more of a step-down type unit where our lytics go, where all these nurses are trained well on it. And then the administration, letting them know what's going to be needed up front if there's any financial investment, but then also knowing that when you're identified as the system in the hospital that sees these complex patients, that is a massive feather in the cap for administrators in ways that they can promote the hospital if you're in a competitive environment. But then they can also help navigate the committees. You know, our VP over our area kind of knew the landscape of the committees, the personalities, et cetera, and she was key in helping us kind of set up a game plan on how we wanted to go about things. So the continuum of care. Think about the efferent limb of patients coming in, the evaluation, the efferent limb of patients going out and getting treated and delivering that care, and then the follow-up. How are these patients going to be followed up long-term? So Sam, I think it's very important to you know, make it a democratic activation process so that any clinician could activate the system. You know, a lot of nurses will activate the rapid response teams. I think even you know, making it that democratic that if you have a known PE, that the team is just activated. I think that's a great goal for any hospital or system to get to. Many programs will have a single number to contact so that all phones go to a central call service. If one specialty is the primary evaluator, the number could go to their clinic or their on-call process, and that's what we have. We have a very well-known number, and whenever there's PE, our number is called, and the primary evaluator is activated, and the team goes from there. So the contact to call for the PE patients will be posted wherever the rapid response numbers. You know, they have the placards at the nurse's station. Everyone seems to carry the lanyards with all the pertinent phone numbers on it. This should be included on that. In the ER, primary care clinics, etc., there should be a little card or a placard that has the number to call for this. Educational campaign, grand round seminars are huge. Monthly department meetings are probably even bigger. We went to ER meeting, pulmonology, hospitalists, surgical subspecialists, and we did the monthly department meeting rounds. You know, they have their meeting, they're allowed, you know, they'll say, yeah, come take 10, 15 minutes at our meeting when every hospitalist is there, when every pulmonologist is there, or a huge number of them. And you can really get them up to speed on what's going on. Health staff conferences, if you've got residents, fellows, etc. These are excellent ways to disseminate knowledge throughout the health staff, and that'll trickle through to the attendings, and that's a great way to get your promo active because they're kind of, you know, obviously the worker bees that get things done. And then the nursing supervisors and charge nurses. So we went to all the units and hit up the head of the floor, the nurse manager of the floor, as well as all the charge nurses, and kind of disseminated it when we put our things out there. So the primary evaluator is a nice way to roll. So yeah, you know, a primary evaluator is the one that ensures a complete evaluation and kind of make sure that all the proper information is either ordered or getting ordered, and then assimilates that. So obviously, history, comorbidities, etc. An exam, get a CTA. Most patients already have this. That's how they diagnose it. But then looking at the clot burden on that CT, the RV-LV ratio, biomarkers, EKG, echo, being sure that this information is collected or in process and soon to be resulted. So then a team discussion. You can do this in person, which is fairly old school. You can do a conference call or a web meeting. We tend to actually do the phone call method. It works better for us. It's practical. But all information is presented, and then a treatment strategy is planned. You know, a discussion ensues with all the pieces, and then conclusion is reached. Then you mobilize the resources. You know, angio suite or OR. You should let the ICU or unit where these patients are cared for is activated and known, so you have a bed to go to. And then the primary evaluator returns to the patient family and discusses the conclusions of the plan and talks about that with the patient and gets the green light. So follow-up is very important. This is something that you can't forget about, is who's responsible for the primary follow-up. You know, managing anticoagulation, evaluating recovery. Do they have persistent dyspnea, pulmonary hypertension, hypercoagulable disorder evaluation? Then the post-procedure follow-up as well. Is there any access or wound healing issues with an IVC filter placed in any of this, and is there a definite plan for removal? So deciding who's going to be that primary person. Usually it's the primary, whoever's the primary evaluator, or usually there's a specialty that's the primary evaluator. They tend to be the people who are the primary follow-up people as well. And then if there's other problems that arise, that patient gets plugged into the appropriate people. And then looking at tracking evaluation. So keeping a database or looking at outcomes. Having a monthly or bi-monthly meeting to discuss business items, education efforts, review cases, troubleshoot logistics, and then look at, hey, these are our numbers, these are who we're treating, by our different methods, and these have been our outcomes. And then looking back at your evidence and the algorithm that you're working off of. So some issues and challenges. Local resources can vary. Abilities to adapt to skill set and environment. You need to convene acutely when practitioners may be otherwise engaged in different locales or in procedures, or you might be at home on home call. The acute nature of PE leads to some inconvenience and potential increased demand on call. That's a big thing that we considered when we started this and saying, hey, we got pretty busy practices. Do we want to put this on top of everything else as being the primary evaluators for this and the primary ones who are carrying this forward? Do we want to be the ones that really assume this burden of call? And on the front side, you really don't know, how much that's going to burden you. Is it going to be something that happens, once a week, once a month, or, once a day? And we found that burden has kind of been not too bad. It's been manageable. Usually it's about a PE that we end up treating once per week. We might get called on anywhere from 1 to 5 PEs a week. And as far as like doing an intervention on one, we might do 1 per week. But the phone calls and the triage, that tends to be, after you get this up and running, you kind of get your algorithms down, and the team kind of gets a certain mojo about themselves and how you work things, and that is pretty smooth. So some other issues is you might only have one specialty, one specialist that's billing the patient for initial consult, and but all members of the team might be liable for decisions made as well. And development expertise by members of the team may be at the detriment of primary care providers, becoming less sensitive to the evolving care of PE. And that's one thing that we really struggle with in our system is a lot of primary cares are still fighting for autonomy and to be kind of the doc, but yet obviously the overall thrust of healthcare has been more subspecialization and delivery of care in that model. And that's something that we've kind of worked through, and it's kind of a site-by-site, clinic-by-clinic area. That's one thing that when we went out and did grand rounds, we also went out and did kind of a grand rounds at the monthly department meetings. We attended the monthly department meetings of every family practice clinic in our hospital area. And we divided that up among the 4 different partners in our group, and we each took a different week and a different meeting, and we went out there and talked about this program and the current algorithm and whatnot with those primary care providers, and that created a huge bridge for us to those providers. So this is an example here with a Mass General, QPE in the ER. The team is activated, evaluation by the primary on-call physician, gathers information. They do a web-based video conference. You get all the specialists on there, discuss the evidence and the results, come to a consensus, and then those options are presented to the patient family team or patient's family and the care team, and then action is taken. This is an example of what we do, quite similar. The PE is diagnosed usually in ER or any place, so inpatient ward, ICU, etc. We're the primary team, so we'll get called to be the primary evaluator, similar to Mass General's model. If the patient's an extremis, we'll immediately, we'll get pulmonary critical care activated, cardiac surgery, and usually we'll, if it's some of the extremists, we usually show up in person in ER. We probably usually all make it there about the same time. And then looking at systemic TPA versus surgical embolectomy versus endovascular embolectomy in that situation. With the submassive patient, which is the more norm, which we've been talking about, we'll go through the primary evaluation, physical exam, are they hypertensive, tachy, etc. What are their symptoms and severity, venous engorgement on exam, etc., DVT, any signs of DVT. We'll get biomarkers commonly. You'll see, mildly elevated troponins and DNP. And that's an important one, too, because when you start this, we had a lot of ER docs saying any troponin leak at all, immediately MI. And we had some patients that, cardiology was called in advance and when it was really a PE. And so that's kind of helped to straighten that thinking. If you got mildly elevated troponins, it's not a time to maybe freak out echocardiology, but really put PE at the forefront of your mind as well. That's, I think, has really benefited our patients. But EKG can have a variety of findings. Red bundle branch block I found to be one that we see fairly commonly. Then look at the CT. What's the clot burden? I like to see that clot burden, go to at least a main pulmonary artery. It doesn't have to be a true saddle. Sometimes a left main, just a one-sided main pulmonary artery, more obstructive thrombus can be much more detrimental than, quote-unquote saddle, which is more of a string, a stringy saddle going from one side to the other, if you will. We look at that RV-LV ratio over 0.9, and our chest radiologists have been, and those that read the chest CTs have been very helpful with that. They've been When we went and talked with them initially, when we were assembling the team, they were very excited about being a part of this and about adding this to to their reading algorithms. And then echo, is there evidence of right heart strain by echo, dilated right ventricle, hypokinesis, a flattened septum, or elevated PA pressures? And our cardiologists read the echoes. We have a pulmonary hypertension program here as well, so we went to the cardiologist and said, hey, this is what we're doing. This is really what we need from you. And they were very excited about coming on board with that. And we said, well, we're going to need a stat read, sometimes at inconvenient times, and very helpful to us that they were pretty on board with that. We have a large department of cardiologists, and so in reality that varies sometimes because they get very busy as well and call down. But they've been very helpful in that regard, and that's been a huge win on getting them to come on board and be excited with us on that. So if, in general, if they're not an extremist but they have evidence of right heart strain based on the things we just went through, we'll proceed. Our primary treatment is to proceed with ultrasound-assisted catheter-directed lytic therapy. Our protocol is to do a 12 centimeters in general. That's the length we use. That covers the pulmonary artery nicely. You can select usually into a subsegmental branch as well that has the most clot burden and really cover the main and the subsegmental branch with a 12 centimeter catheter. And we do 1 milligram of TPA per catheter for 4 hours, and then we drop that down to 0.5 for usually a total of 12 hours. We run the coolant at 50, heparin at 300 units an hour to the sheaths per sheath just to mainly keep the sheaths paid. That's not a treatment dose. And we will generally put in 2 6-French sheaths, one on either side, if there's no contraindications to that. So PA pressure, we'll check that at the bedside with an outline setup, and then we confirm with clinical improvement. When we first started doing this, for the first probably year and a half, even 2 years, we would take every patient back at around 12 hours and check a pulmonary angiogram, PA pressures, etc. We found that that really wasn't changing what we did based off of clinical parameters. So what is their heart rate or blood pressure doing? What are their O2 needs doing? What are their symptoms like? And then checking a PA pressure at the bedside. So we switched from taking everybody back to doing a bedside assessment based on clinical parameters and a pressure measurement and descing the lines at the bedside. And that really helps streamline care as well. What we found is most patients, if they were a little tacky or a little hypotensive, a little saggy, and their O2 needs usually change between that 7 to 10 hour point, that they would really, their O2 requirements would go from 8 or 10 liters down to 2. And usually that 2 liters, I joke, was just more for the nurse to keep them comfortable than the patient. That they're breathing, you go in there and say, how are you doing this morning? Oh, I'm doing so much better, doc. You get that very, very commonly with this. And that's very good. And we found that, again, it wasn't, wasn't changing our parameters of going longer. So that's generally our protocol now of when we stop. Now, if they're hemodynamically stable, no evidence of right heart strain, we'll initiate anticoagulation, evaluate for DVT with the duplex, etc., and go that route. Generally, we save IVC filters for acute DVT PE with an inability to anticoagulate. And then follow-up, if they're on Coumadin, that's the route we go with for anticoagulation. We have an anticoagulation service run by our RMDs. That's very helpful to us. But we do generally, kind of our primary method now is to put people on Xarelto or Eliquis as a primary method of anticoagulation for an oral anticoagulant. So we see all patients back. Our general follow-up is 1 month and 6 months. Clinical assessment, if they have any clinical signs, persistent shortness of breath or pulmonary hypertension, we'll get pulmonology, we'll kick them to pulmonology as well. Hypocoagulable studies, we generally got, when I started out, we were getting them on a lot of people. Now we save those for people with recurrent episodes or mainly young patients with an unexplained episode. They had an unprovoked DVT or PE, and they're young, even under 50. We'll check that over with a strong family history. So if they had an IVC filter placement, we'll discuss that. Usually we take that out at 1 month, and then we'll discuss the anticoagulation plan as well. Generally, we'll anticoagulate for 6 months. If it was a provoked episode, in a first episode, we'll stop. If it was a second plus episode, we'll generally consider a longer-term anticoagulation for that patient. And then we're very fortunate to have a dedicated research assistant that tracks our patients for us. But even if not, this could easily be something that could be done by a nurse or even an LPN could keep a simple database of this. So this is our experience. This is a retrospective review we did of 45 patients from January, from basically 2011 through 2013. kind of early on in our experience. And we looked at 45 patients treated versus a cohort control group of 45 patients matched to severity of PE and comorbidities. So we had hypertension was actually based on systolic pressure less than 100 was present in 12 other patients, and all those resolved by treatment completion with the EKOS. We had 26 patients with tachycardic over 100, and that resolved in 92%. The average heart rate decrease went from 109 to 77 over the treatment period. And like I just said, between that 7 to 10 hour period where we'd see that just kind of drop like a rock. And then the direct pulmonary pressure measurement, we were doing that a lot through this time. Sort of an average decrease to 21 millimeters of mercury, representing a 40% reduction in PA pressures across our treatment time. So Professor Echo showed complete resolution by treatment completion at 64%. I think that goal jives with that early slide on the EKOS studies we showed, that colorful slide that showed good resolution even out to 90 days with most patients returning to be normal and mild. So we had a total dose of 30 milligrams of TPA in our study. And we did the average infusion time of 14 hours. Since then, we've kind of trimmed that back. A big reason for the average dose is one of our providers early on really felt strongly about bolusing the patients. So they'd get in, they'd bolus actually 30 milligrams up front, and then they would do our protocol. So we subdivided those patients out too and saw that, a bolus or no bolus made no difference in outcome as far as clinical outcome. The EKOS based on the protocol was enough. And then we also found we didn't have increased bleeding complications from that, but we could decrease our overall dosage of TPA by going straight with the catheters with no bolus, and we had the same results clinically. So we had no deaths through 90 days and no major bleeding events. So that really demonstrated the efficacy. This is looking at overall length of stay and mortality. We did show a mortality improvement based off of the cohort control group as well as length of stay, which is a little less than half for the treatment group. And now I'd say, we do have patients that come in for length of stay, and we'll, see them. They'll come into the ER one day, in midday. We'll get them going, say, 4 or 5 o'clock, for example. They'll be done by the early morning, and we will send them home that day. So they'll have literally a hospital stay of, 24 hours or so. And, we've developed that comfort level over the years now with the clinical improvement we see, and we have a protocol where we have them, walk the halls, do a walking, saturation test, etc., and get them on oral anticoagulants and get them out. So this is an example of our clinical practice guideline, and this is just a quick, copy of what we've come up with. This was developed in conjunction with our multiple specialties. So mainly pulmonology and hospital service were the heavy hitters along with us when we developed this. Now, when we started to do this, our method was going around first to the key players in the hospitalist group, the head of the hospitalist group, and then the head of the pulmonology group. And then we also went around to the ICU unit and our cath lab and said, hey, this is what we're thinking. Are you guys able to help with us and accommodate this? Are you excited about this? So we kind of gathered support informally. And then we started talking about, well, if we're going to do this, our clinical committee structure was such that we had a clinical practice guidelines. We said, well, let's get guidelines in place and then have everybody on board with how we're going to treat this via our algorithm and our guidelines on who should be referred, who should be considered for treatment, et cetera. Kind of get that in place first. We kind of have a general agreement, and then we can launch our program. And that's what we did. And that really, through the process of putting the guidelines together, that brought everybody to the table because we invited them. We said, hey, we're putting this guideline together. We need your help. We need your input. That really helps break down, particularly our pulmonology group. We had an older pulmonologist who's very much against this and very kind of stern, to say it nicely. And when I showed up at their meeting and I said, hey, we need your guys' help and your input on this because you guys are a primary player in this, that really broke them down, and they started helping and being collaborative and saying, hey, this is what we think should be in the protocol. And we got everybody's thoughts, and we took it to the committee actually 3-4 different times, revised it. And that was kind of a time-intensive process, but that allowed us to kind of get that ground level support, and everybody felt that they were a part of it just from developing our guideline. That was just based on our local process, our local committee process. That was a great way how we broke down some barriers. And then this gave us, we did this for PE, DVT, upper lower extremity DVT, and that gave us a great thing to go out there and promote then, hey, we've got guidelines, we've got a treatment process and a treatment team, and it kind of just really hit the waves all around our system. That gave us a good thing to talk about either in grand rounds or meetings.